We next turn our attention to post-traumatic stress disorder, or PTSD. Seem to be increasing questions on PTSD, probably because we're seeing increasing cases of this in real-life practice. In order to give a diagnosis of post-traumatic stress to your patient, you must have the following two symptoms. One, re-experience of the event as dreams, recollections, or flashbacks, and two, avoidance of associated stimuli. If you don't have re-experience, you don't have avoidance, I don't want to hear PTSD as the diagnosis. Please notice, we're diagnosing post-traumatic stress not based on whether or not someone's had a traumatic experience, but their reaction, what they do in response to the stress. Key symptoms, re-experience, and avoidance. Now, if you have all of these symptoms, but you've had them under 1 month, you still have a problem, you just don't have PTSD. If you have the symptoms under 1 month, we call it ASD, acute stress disorder. What's the difference between PTSD and ASD? Simple. How long have you had it? Under 1 month, ASD. Over 1 month, PTSD. Now, in addition to these key symptoms, re-experience and avoidance, there's a host of secondary symptoms we see that characterize PTSD. The patient usually has diminished response to the world. There's a turning inward, a turning away from the environment. They may sleep a lot or may just have difficulty sleeping at all. Almost always there's irritability, there's a losing control, there may be an outburst of anger, certainly impulsive behavior. Headaches, inability to concentrate, distractibility, almost always part of the profile, and repetition compulsion. All right, now admit to me, if all you saw was that repetition compulsion, you'd think about obsessive compulsive anxiety disorder, right? Here, if you see that repetition compulsion in the context of all the other symptoms, don't think OCD, it's simply a part of post-traumatic stress. The repetition compulsion you're going to see in the context of post-traumatic stress is most usually about keeping yourself safe and protected, in some sense trying to keep away that trauma which is lingering in your mind. So it's as simple as a woman who is raped finds that before she can go to bed each night, she has to check all the locks and all the doors and all the windows of the house about 10 different times. That's a repetition compulsion consistent with PTSD. Please note, you only have post-traumatic stress disorder as the result of an event outside the realm of normal human experience. This is not an excessive reaction to a common event. This is an excessive reaction to an extraordinary event, a once-in-a-lifetime threat to your home, your family, your very way of well-being. It's a very common reaction in women who have been raped. Now, I'm not saying that every woman that's raped gets PTSD. That's, of course, not correct. But when I talk about post-traumatic stress disorder, many people think about soldiers. And although, yes, we do find substantially higher rates of PTSD in soldiers, one of the most common reasons why you're going to see it is in women who have been raped. Often, there could be a long latency period. That maybe someone has a trauma when they're a child and the PTSD symptoms appear when they're an adult. And that's too bad because the quicker the onset, the better the prognosis. People that survive a burning building and have their post-traumatic stress symptoms immediately, they have a much easier time of recovery than people whose symptoms might appear 3 years, 10 years, 20 years later. PET scans of the brains of people with PTSD show pretty uniformly sustained amygdala activation. And that gives you a way I want you to think about the PTSD. The amygdala, remember, is important for emotional tone, emotional memory. It's the emotional responsiveness. And in some very real sense, in PTSD, the alarm button gets pushed on and it gets stuck. And the person with PTSD is stuck in that constant state of alarm. They can't change their behavior to match changing environment because they can't relax even though there's no alarm there. The alarm is always there. They're waiting for the other shoe to drop, to use that metaphor, all the time. Certain people are more vulnerable to developing PTSD. If you have prior emotional variability, you're someone that reacts strongly to things, more likely to develop PTSD. And there's also some research evidence that people with any history of cocaine or opiate usage much more likely to have PTSD. Note the prevalence is higher in women. That catches you off guard because you're thinking about soldiers. Remember the rape issue I mentioned before, and that explains the higher prevalence in women. What are we going to do to treat PTSD? Well, we do give drugs, SSRIs are used, but let's understand why. We're giving SSRIs not to treat the PTSD, but to raise the patient's functional level up to the place where they can then participate in the real cure, which usually comes in terms of group therapy. In the sheltered, nest-like confines of the group, the person can watch others deal with their trauma, face their fears, and they can, by modeling and with the support of the group, learn to face their fears. Because all you have to do to get somebody over PTSD is get them to go back, revisit that traumatic event, and have a different, less overwhelming response to the event. This is not easy. You want them to go back and revisit what is, not metaphorically, but actually the worst thing that ever happened to them in their entire life. The last thing they want to do is go back there. They're going to do anything but go back there. They're going to do drugs, run away, get into fights, all things you should recognize as the defense mechanism of acting out, trying to fill themselves with these other sensations to keep out that recurrent PTSD arousal. Now, the US military has had some great success using beta blockers as prevention for PTSD. Soldiers coming back from the Vietnam War, we had rates of PTSD that were roughly about 75%. Soldiers coming back from Iraq and Afghanistan, rates of PTSD range between 20 and 25%. Now, 20 and 25% is not good, but it's a whole lot better than 75%. Why are we getting these lower rates? Well, first, we put people on the ground so we can interact and help people sooner. Dealing with the symptoms sooner is better than delaying it. But also, they've been using beta blockers. We don't put soldiers on beta blockers all the time, but this is what you do soon after they have the traumatic event. A patrol is out, ambushed, people die, people are blown up. As we're bringing the patrol back into base, debriefing them, we hand out the beta blockers. Now understand, I remember I said it's as if that alarm reaction gets stuck. Well, if we can give something that keeps that alarm reaction from going quite so high, we don't get stuck and we don't have the incidence of PTSD. This is in phase 3 clinical trials in the civilian population. It's something that I expect you're going to see and be able to use as a, remember, preventive measure in the civilian population. I want to emphasize again, we don't give beta blockers to treat PTSD. This is prophylactic. Now, I just want to make one final point about PTSD, which is actually an important historical moment. Research has shown us that patients with severe PTSD, we have this increased, intense, sustained activity in the amygdala. Well, we've also been able to show that when we put people in therapy and they are better, we have success in therapy, they're more functional, they're able to deal with the world more. At that point, we take a PET scan of their head. We see, one, increased activity in the rostral anterior cingulate gyrus, and two, great reduction in amygdala activation. In short, what you're seeing in the brain is what you want. More cognitive framing control orientation, that's in the rostral anterior cingulate gyrus, and less emotional, overwhelming response, that's the reduction in the amygdala activation. In the face of fearful stimuli, you're getting more cognitive framing, less emotional reaction, and that's really the solution to PTSD. I said this is a historical moment because this is one of the first times we've actually been able to show changes in the brain as the result of successful therapy. We've seen this for PTSD. You're going to see more and more of these studies where we can not only say they're better, but we can actually document, look at what's happening to change brain activity.